So I am Emmanuel Sudre from Lumibird Medical, application specialist for the South Europe, Middle East, and Africa countries. So I'm gonna to develop today the concept of the laser for treating glaucoma. So we have two main topics: the SLT laser and the diode laser. So my first topic is the introduction of the laser trabeculoplasty. In the past, there was the argon laser trabeculoplasty, which is considered as the old technique that use a traditional argon laser, 514 nanometer, which has giving damages to the trabecular meshwork because the technique was to make small holes in the trabecular meshwork. The new SLT technique, which is not new now because it exists since 20 years now, developed by Dr. Mark Latina. This is a use of larger spot, 400 microns, that do not create any damage to the trabecular meshwork. Okay, you can notice on this picture that there is no visible damage. So it is a really short pulse that is delivered to the trabecular meshwork without any scar and damage to the tissue. So, okay. So how it works, there is a stimulation, we call it the photothermolysis. There is stimulation of the pigmented cells, there is irradiation of the melanosomes into the trabecular meshwork that release macrophages that will clean the trabecular meshwork. We will see in this video exactly what happens. So I have to deactivate my pointer, sorry. Okay. So on average, SLT achieved 30% reduction on IOP as a first-line therapy. We use a one mirror lens, gonio laser lens that has factor 1 magnification factor. We deliver a 400 micron spot size with a short pulse duration all along the trabecular meshwork. So the spot size is fixed. Usually we deliver 50 spots over 180 degrees. The spot size is 400 microns, and we have champagne bubble effect. That means that we do a little cavitation effect, that it is the threshold of the laser effect. So usually we use between 0.8 millijoules to sometimes 1.2 millijoules, and we have to play with this energy according to the bubble effect. So we should reduce by 0.1 millijoule if we have too much bubble. The process exactly is stimulation of the tissue. The process stimulates the release of proteins and cytokines and the recruitment of macrophages to improve the circulation of aqueous humor through the trabecular meshwork and at the end through the Schlemm's canal. So you can notice what happens exactly. So it is a cleaning process. So this selective photothermolysis takes place at the cell level, producing a wound healing effect without causing structure damage to the trabecular meshwork. So due to this restorative and non-destructive mechanism, so SLT does not cause scars into the trabecular meshwork, making it an ideal adjunct to other glaucoma procedure, including mixed procedure, for example. So 1 to 3 days after the procedure, IOP should drop significantly, although the IOP lowering effect could take up to 2 weeks in some patients. So depending on the postoperative risk of pressure spike, follow-up visit can be scheduled at 1 week or 1 month, 6 months after the treatments. So okay, I will not develop this take-home message. It's up to Dr. Sow right after. So it's just real simple procedure. In office that takes 5 minutes, we can expect 30% IOP reduction. So, and as well, it can be repeated. It's quite simple. So my second topic today is to talk about Subcyclo, which is the new use of the diode laser. So the Subcyclo is as well known as subliminal therapy or a pulse mode. We use 810 wavelength nanometer laser that is delivered through the sclera thanks to the use of a probe. So this probe is applied directly to the sclera, but we pulse the beam in many parts to deliver just short pulses, and the tissue allows to cool down between each pulses. Compared to the traditional thermocyclo, the TSCPC, which is transscleral cyclophotocoagulation. So this subcyclo technique has three hypotheses. We can get a slight coagulation of the ciliary body. This decrease a lot the aqueous humor production, but at the same time, we have a kind of stimulation of the uveoscleral pathway. So it increases the uveoscleral aqueous outflow at the same time. So, and we have a third hypothesis, because of the laser effect, we have a contraction of the ciliary muscle. So there is probably also an angle opening, which facilitates the increase of the trabecular outflow. So just look at this video showing the technique. We apply a probe slowly by gliding over the sclera, more or less at 3 millimeters from the lumbus, and we deliver this laser over each hemisphere during 80 seconds, maybe more sometimes. So this is a gentle way to treat patients. It is not invasive procedure. It's quite fast, and it can be done as well in office. So my advice for this technique, you notice that we have to put some blue dots at 3 millimeters from lumbus. It is the conventional technique, but newly we introduced the fact that it's better to do transillumination, because the transillumination helps a lot, and then we can notice where exactly are the ciliary body. So in this case, it's an option that we recommend to help you to identify clearly and then to treat correctly and follow strictly the anatomy of the patient, the anatomy of the ciliary bodies. So how to do transillumination? There is many possibilities. Any codelizer from the operating room can do the job. So we put the light cable over the cornea, not in contact, and use the blue pen, the skin marker, to draw the dots where to treat. Otherwise, any microscope, if you have slit lamp integrated, it's easy. Otherwise, you use the main light and just displace on the sclera, and then you can notice that we can get transillumination on the opposite side. So it helps to use the blue pen to draw some dots before doing the laser treatment. So this video to show you how to do this transillumination. So by using an external light source, then you can notice that we have the border between the white area and the black area. We just have to draw exactly below the border some dots. And then after that, by using the laser, we just have to follow the dots. Okay, so it takes 1 or 2 minutes to do the transillumination for both hemispheres. And when it's finished, then just use your probe, do a slow gliding, and then we deliver the laser. So it's quite easy to use any light source from the OR. We have as well guidelines available. I will not enter into the details. So the take-home message for Subcyclo is that with Subcyclo, you can broaden the indications. This laser has good safety profile because you avoid the transient, the side effects from the thermocyclo. It's repeatable. It has a long-term hypotensive effect, almost a 30% reduction. It reduces the number of medication. This is a safe alternative to surgery, and it's a quick procedure. So far, we had the SLT should be considered as a first-line therapy, at the same level as drops, and Subcyclo and the diode laser for other stage of glaucoma, from moderate to end stage of glaucoma. So these two lasers is a good combination when in some countries drops are not, patients are not compliant to drops, or surgery is not available, or surgery is not easily accessible for the patients. Just a quick reminder, but what is thermocyclo? It is the old technique, which is quite aggressive for the tissue, deliver high energy to the tissue. The probe positioning is quite different. So you notice that Subcyclo is perpendicular to the sclera, and thermocyclo is parallel to the visual axis. So just keep in mind that with the same probe, we just use it differently depending the technique. So at 2.5 millimeters from the lembus, more or less, we apply the probe to deliver some spot, usually 2 watts, 2 seconds, until we get the plop effect, and then we reduce a bit the energy to avoid the tissue destruction. So we have as well a protocol available. We'll not detail it today. It's not the topic, but you can rely on it, of course. So for Subcyclo, as it is thermal treatment and has some side effects like hypotonia or vision loss, we recommend to use it with patients with poor visual acuity after multiple surgical failures or blind eyes. Okay, so now it's turn to Professor Mario de la Torre to develop his topic.
Okay, let me introduce myself. I am Mario de la Torre. I am professor at the University of San Marcos in Lima, Peru. It's the oldest university in America. It has around 475 years. It was founded by a Spanish viceroy. With the Mexico University are the oldest than every single other university in America. I made my doctoral degree in Germany with Professor Hasenfratz and Professor Kampik in ultrasound and also in glaucoma. I also make a scholarship at Duke University with Dr. Shields at Duke University, and then right now I am the scientific director at Quantel, and it's very, very happy to be and talk with you, because I want to talk about this, the glaucoma laser assisted solution. We call it GLASS, for the patient's benefit, and especially in the sub-Saharan area. This is very important because we have the proof of the concept in the development of the light study. The light study opened the doors to all of us in the scientific community to be sure and to be convinced that SLT is the first line, also together with the eye drops. What is the problem? The problem is SLT is not new. SLT have a long time, but it was a bad luck that it goes to the market just at the same moment that analogs of prostaglandins become. And we are often doctors, we have habits, and our habits sometimes are very hard to change. In this case, right now, because we have enough scientific evidence with the light study, we can talk about it. Why you, in your subcontinent, in your continent, that you have special situations, you have in some places where a lot of burden with the public system, a lot of burden with the drops, cost, the patient, the compliance of the patient is different. Right now there is an option, because it's not only clinical, it's also technical and economic, the implications of this light study in the Sub-Saharan Africa. This is the study. Yeah? Gus Gasser, a very good friend in London, was the leader of this study, and it was, and this is the second one, is the 6-year result of primary selective laser trabeculoplasty versus eye drops in treatment of glaucoma and also ocular hypertension. Okay, what is the light study? Let's talk about that because it's our weapon. The main objectives of the study, we will talk about that. We will talk about the methodology and the study population that they use, the key findings, the comparative efficacy in reduction of intraocular pressure, and the duration of the effect and reintervention rates, because there are also questions that they are also asked. Okay, what is the light study? Is to address the critical need in glaucoma management. Why? Because we see that drops, we have a lot of problems with the compliance of the patient. What was the primary objective? Is comparing long-term effectiveness of initial laser treatment versus initial traditional hypotensive topical eye drops. Yeah? And in naive patients with ocular hypertension and primary open-angle glaucoma. It was the primary objective, to compare it. The secondary is the long-term sustainability of IOP reduction, efficacy, rated of the treatment, also complications, that is safety. The most important thing to demonstrate if there is adherence of the patients, and the most important, because the patient is keen, is the quality of life of our patient. Perhaps you have we ophthalmologists, we people who is involved in the treatment or in ophthalmology, when it's our turn to use eye drops for eye conjunctivitis, something, we have no adherence to the treatment. We, the ones who we are leading the treatment, you can imagine a person who will use eye drops, okay, at least one time in the day, every single day during the whole life, or 2 fixed combination plus analog of prostaglandin, or 3 or maximal therapy. It's very complicated. And also the cost and the economic implications of the application of the laser at first line, especially in resource-constrained environments. It was a prospective, multi-center, randomized control trial, very, very explicit. Evaluation after 3, and it was extended to 6 years because it was good. And health-related quality of life, it was measured, the profitability and the clinical efficacy. What are the methods? They use selected naive patients with a diagnostic of ocular hypertension or primary open-angle glaucoma in one or both eyes, according to the UK NICE guideline. It was done in October 2012 to October 27 in 2014. 6 hospitals in the United Kingdom. The inclusion criteria was age more than 18 years. Visual acuity was not a complex, it's 20/125, and important eyes without prior intraocular surgery, except phacoemulsification. Exclusion criteria, contraindication for SLT. You know, it's very good to have always in our goal the target IOP. The target IOP and monitoring intervals was done using the Canadian Glaucoma Management Workshop, mild and moderate and severe ocular hypertension and glaucoma, and the specific IOP target was taken from baseline IOP without treatment 1 month with a washout period as well. But in that case, they don't use the wash time, they use naive patients. And what was the target? The target in every single measure of intraocular pressure was to reduce 20% and to observe no glaucoma deterioration. It was the follow-up was a regular intraocular pressure, monitoring adverse events, and evaluate treatment adherence. Why? Because one of the fear that we had in the past, doctor, is okay, is really the intraocular pressure decrease? We are using laser. Is there some adverse events? And the people happy to have that kind of treatment. In other words, with laser, the treatment is not in the hand of the patient, it's in the hand of the doctor, and that's just better. The data collection was the IOP measure and visual field, and reported outcomes. The most important link was with the quality of life and satisfaction for the treatment. Okay, the last report, okay, the first stage of the study at 2019, the initial SLT, the first line SLT treatment for patients with ocular hypertension or with primary open angle glaucoma was more cost effective than initial treatment with drops after 3 years. This is extremely important. I come from Latin America, and we have sometimes same problem that we have in Africa. You have in Africa, in some parts of Asia, costs of medicaments are very high. And okay, you can tell me, okay, but use the laser could be one cost, but it's one time, and we have time to observe the treatment. Anyway, the result show us that the initial SLT is more cost effective. And the most important thing, in something like 74% of the patients, they had drop independence. No uses of drops, and less number of glaucoma surgeries, and very low rates of adverse events. Okay, but they saw comparison. Remember, one of the first goals of the study is to comparison? Yes. With SLT patient, it was a rapid and sustained reduction of the intraocular pressure and a long-term follow-up. Fewer additional interventions or adjustment in the therapy. In my hands, for example, I have patients that have 3 years or 4 years without repetition of treatment. And that is very relevant for areas like Sub-Saharan Africa. Your patient will be safe for 1, 2, or 3. It all depends the reaction, the immunoresponse of the patient. With eye drops, they saw that initial reduction of the intraocular pressure is the same. I mean, if you compare the goals, they are similar, but an effect less pronounced over time. Why? Because there is a lack of medication adherence and a lot of variation in individual responses. The key findings when you compare efficacy and reduction in intraocular pressure is SLT seems to be, according to the LIGHT study, and a superior alternative in the treatment of glaucoma, especially in places that we don't have enough money to invest in our treatments, in places with resource-limited settings. That happens in Latin America, in Sub-Saharan Africa also. SLT seems to be more reliable on time intervention, reducing burden of patient and healthcare systems. That's the most important thing, because they have better long-term outcomes. The patient doesn't need to have the medication, and that drops the adherence, etc. already the SLT advances. It gives you effective IOP control, reduce dependence on daily medication, improve patient adherence, and quality of life. All the goals that the light was looking for in the study were accomplished. There is another advantage, not only because it's good, not only because it works, but not only because it's safe. This is an outpatient and quick procedure. Minimal invasive, short time in the procedure, quick recovery. Dr. Sow, we talk about his experience about that, and reduce healthcare burden in some countries. No systemic or less systemic and ocular side effects if you compare with eye drops, beta blockers, for example, or brimonidine, or another. There are a lot of things that they have side effects. SLT has no. It is important also because in patients pregnant, you can stop the treatment with drops and you can skip or shift to the laser treatment because every single glaucoma drop has consequences. They are type C. That means they have effects in the fetus and in the product that we have. The long-term complication risk is SLT is stable in its efficacy, reduce compliancy. That means the patient that sometimes, believe me, sometimes I see the patient at my hospital. They come, oh, doctor, I come with a bottle. I didn't finish it. Why? Because the cost is so high, and I use it one day, and the other day I don't use it. Then I look that it is finished quick. That's the kind of history we heard. Oh no, I use one drop in one eye and the other day in the other eye because the cost is very high. But laser is one shot, or I mean one session, and then we don't need to repeat it. Situation of IOP because you don't have effect, and also no progression of the disease. You have predictable outcomes. For the integration in public programs, in public health problems, standard treatment, scalability, reduce follow-up demands, and facilitates preventive health strategy. Is in every single situation is very, very positive. The economic advantage is low expenditure on medication, that they are always very, very cost effect. Fewer follow-up visits on management of complications, a positive impact of health system because you save money. Believe it or not, in Canadian study, US study, Latin American study showed that the public health system save money. And also, you can invest that money in other infrastructure. What is the challenge that we can have in Sub-Saharan Africa? There are specific challenges in your area. Limited access to chronic treatments, adherence issues because socioeconomic conditions, and the benefits of the laser approaches, greater viability in resource-limited environments, and you can implement it in community health campaigns that you move the people to the place that you have the SLT. This is my first part. I thank you very much. The message is clear. Right now, we have SLT as a very effective first-line treatment with implication in cost, with implication in the adherence and the compliance of the patients, with very nice and very good results. You can repeat it. Dr. Sow will show you how to do that. Only few things about the tools that we can have in your area for glaucoma diagnosis and treatments and follow-up. I'd like to talk a few moments or a few minutes about the UVM and the study of the angle. The people say, oh, you are talking about UVM, but we use gonioscopy. This is a gold standard. Yes, we have the gold standard, but we can't see what's happening behind the iris. And if you remember the classification of glaucoma, they are all the classification are done by gonioscopy. And that means we never took in account what happened behind the iris, what happened with the ciliary body, what happened with the movement. We have in some speeds, it draws how the position, but it was never so. It wasn't the result of the combination of the planar image of the gonioscope in a 3D in the brain of SPED about what happens in the angle. Right now, we can see exactly what is going on in the angle, and probably it's not very, very efficient in open angle glaucoma. But remember, we have angle closure glaucoma that's even is less frequent than the primary open angle glaucoma. It causes more than the 50% of the cases of blindness in the world consider glaucoma cases. We can see the corneoscleral junction, the ciliocapillary and obliculociliary, and the scleral spur, and we can determine what kind of angle closure are we facing. It's really a pupillary block. It's really a pupillary block. Look, it's a bent iris. It's a plateau iris that, look, there is a space, a little space. I don't know if you can see my arrow. Emmanuel, is this visible, my arrow?
Yes, Mario. Yes,
okay.
We can see it.
Look, this is one mechanism, another mechanism, phacomorphic glaucoma and constitutional. As you can see, if you use gonioscopy in this case, you are not able to see any structure. And you must be very, very skilled to look for, with gonioscopy, that this is a plateau iris. You must see the double hem sign. And sometimes we see all this angle, and we go direct with iridotomy. But you see here that iridotomy doesn't work here because there is no pressure. And it works here because there is pressure just behind the iris, and it closes. And you make the communication between the anterior part of the anterior chamber with the posterior part of the anterior chamber. It releases and opens the angle. In phacomorphic, sometimes you can't see any structure. Okay, what is UBM used for in glaucoma? To address the risk of angular closure, the mechanism that can produce it, and the solution. If you know the cause, you get the solution. I mean, it's avoid to use the iridotomy in cases that it doesn't work. For example, plateau iris, when it's alone, when it's pure, or phacomorphic, that is the lens, the cause of the angular closure, or even in constitutional. We can have all the anterior chamber measurements. It all depends the age of the patient. And we can use the clear scan. That is something that we can adapt. It's discardable and comfortable, easy to the patient. And sometimes we can use also scleral shells to don't use the clear scan that is discardable, that you can make this section to the scleral shells. What to look to determine the angle closure? Of course, where is the trabecular meshwork? And if you can see here in the gonioscopy, you see the Schwalbe line, the no pigmented trabeculum, the ciliary body, the recess. I mean, this is the scleral spur. And you know exactly that if you are in the scleral spur, OVA is the anterior, is the trabeculum, pigmented trabeculum, and this is the area that you can have the filtration. Here in UVM, you trace a line between the white part that is the sclera and the gray part that is the ciliary body, and the point that this line goes to the anterior chamber and close and get in the anterior chamber, this is the scleral spur. That means that trabeculum is 500 microns anterior to this point. And you can decide, oh, it's open, oh, it's not open. Narrow angle and angle closure, they are, okay, let's see, let's get a little bit fun also. Angle closure is very scary. It's a billion, a very bad boy. You see, it can take your vision. It can take your quality of life. And there, in the angle closure, there are posterior anterior mechanisms with the force just come from behind. In this case, for example, you can have a cyst, a tumor, and even in ethnic pairs, or also some rings. And you can also have anterior posterior mechanism that is not well known. It's not so many indication in the books, but you can see a cyst that make compression of the angle, lipoid corneal degeneration that close the angle closure by corneal edema, and that happens also in some places, cosmetic iris implant that close the iris. With UVM, you have an exactly view of that kind of. Pupillary block is very, very important because we have in our hands iridotomy to solve it, but you must be sure that this happened. Why? Pupillary blocks leads a convexity of the iris. I mean, because there is a pressure here, and the accumulation of pressure behind curves it, closing the angle, and the pupillary rim as well. Iris should be in this position, but it was moved to this position. And then if you, in this case, you can perform an iridotomy with success because there is push. Sometimes even the pupillary block doesn't close the angle, and this is important, but it's very difficult to see it with gonioscopy. Also, you have reverse pupillary block and pigmentary glaucoma as well. Phacomorphic glaucoma is very interesting because it closes the angle because the lens go anterior, and you can see the profile, narrow anterior chamber, iris profile in contact with the lens, angle closure, big lens, and inside also intracrystalline and pockets that can give us very bad surprise in the surgery by making the capsulorhexis. Okay, the lens bolt is the measurement how anterior the lens is and how is the risk to have the closure. If you find that this line, you make a scleral spur and a scleral spur line with your UVM, you make the measure of this line to the anterior capsule, and you compare it with this measure from the same line to the endothelium. If this yellow is 1/3, more than 1/3, that means this is the lens. And doesn't matter what you do, iridotomy, therapy, whatever, you must take out the lens as well. Plateau iris is the central anterior chamber medium of beam. You can see very well it with UVM. The iris profile is plane, the iris root is angled, and ciliary body anteriorizate. Look, 1/3 of the ciliary body is very anterior with sulcus collapse as well. You can see also with UVM dialysis that you can see also with gonioscopy. You can see suffusion, choroidal suffusion and malignant glaucoma. You can see cysts that are not possible because the iris is a barrier. You can see also the lens rupture in phacoanaphylactic glaucoma. And right now that is avastinitis, because Avastin is everywhere, there are people that doesn't know how to do that, and they make anaphylactic glaucoma due posterior capsule rupture with UVM and also with echography. For the pulse follow-up, you can see what happened when you, before the laser, you have this vent, and the same patient, the same eye, you can see the opening of the angle because there's communication. Also, penetrating and not penetrating, you can see with the scleral, with the slit down. But sometimes you see this and say, oh, the doctor who did it is not skilled. No, pay attention. He knows, or he knew, that the ciliary body was very anterior, and to do an iridotomy very near to the angle can cause damage and also bleeding and also pain. And sometimes it's not because the doctor doesn't know very well. He is clever and he has a UVM and make the diagnostic process. And you can see also the iridoplasty that function very well in plateau iris. And You can also make the review of your bleb in your trabeculectomy and also all the structure, the osteum, the channel, and also the bleb the day before or after. Also the express shunts device and the valves that you have. I mean, in congenital glaucoma as well, it allows to you to see through the dense corneas or the packed cornea, the Peter syndrome, iridocorneal syndrome, and iridia. That is really not, an iridia is not really an iridia. They are a little part of the iris as well. And Axenfeld-Rieger syndrome in childs. And look this, you are like me. We see in Peru, we see in Latin America, white cataracts, and Africa, I think so. And then we are ready to go to the operation room. And the first thing that we will do is, okay, we look this part. We don't see it because we don't have UVM, but if we can avoid some problems. Look, you enter, then you make the capsular apheresis, try to do it, and you get the Argentinian flag. That is nice to see the Argentinian flag, but not in the operation room. In conclusion, we have still 4 minutes, but I will use less than 1. UVM provides real-time images of anterior angle and segment. The standard biometric descriptor and angle anterior segment anatomy is very good, very, very well seen, and it allows for a quantitative approach first to the diagnosis, then to the treatment and the follow-up. Thank you so much. Yes, to give my take-home message. You should have, in countries like ours, I mean, Latin, Africa, we can work together to use the technology. The technology will do our life easier, will do the life of our patients better. We can optimize our service. The people say, we are making a spend. No, we are making an inversion. We are making an inversion for us, for our treatment, for the patient, for our country, for our public health. SLT, it's one of those things that you will see. Dr. Sow will present us how he managed the patients in his daily life. And also, if you have the possibility to have an extra, not everyone, but I mean, the service, the glaucoma service, they are receiving a lot of patients, or even some glaucoma specialists, you can go one step forward for the gonioscopy, that is the gold standard, but you have the technology to do more than that with the UVM. Okay, thank you so much. It was very nice to share with you this experience, and we will let Dr. Sow to talk about the experience that he has in the laser technology for glaucoma.
Okay, so thank you everyone for joining us to this webinar. My name is Saidou Sow. I am a Senegalese ophthalmologist working to the Saint-Louis Regional Hospital in Senegal. I will be talking about my experience since the 3 years using SLT and diode laser for the management of glaucoma. So as Professor Marion said, we know that in Africa, we are dealing with a lot of challenges. We know that the glaucoma is a leading cause of global irreversible blindness. The prevalence of primary open glaucoma is highest in Africa, and the prevalence of primary angle closure glaucoma is highest in Asia. We have 76 million people affected by glaucoma in 2020, and by 2040, about 112 million will be affected. In many African countries, we are facing some challenges with our patients because they are a poor knowledge of the disease, a poor adherence to the medication treatment, and also a poor acceptance of the surgery. There are a variety of glaucoma treatment. As we know, there are drops, can be mono, dual, or triple therapy with various molecules. But in Africa, we are facing a poor adherence to medication of compliance with our patient. Sometimes the cost and the availability of some product can be very challenging in some areas. We have the surgery that can be trabeculectomy or sclerotomy, but also there is a poor adherence to surgery in Africa, maybe due to a lack of understanding or the cost of the surgery. And finally, we have the laser treatment that can be trabeculoplasty by SLT that can be used for the early or moderate stage glaucoma. We have also the cyclophotocoagulation with two options, the thermophotocoagulation that Emmanuel have talked about, and we will talk about the pulse subcyclos, that is the new modality. So this is a general observation that the place of lasers had evolved. We know that when treating glaucoma, we start with the simplest and the best tolerated, and we increase step by step in case of progression. Often we start with a mono or dial therapy medical treatment. We propose SLT on poorly tolerated maximum medical treatment, then filtering surgery, and as a last resort, we propose the diode laser. So we will see that SLT has evolved thanks to major studies such as the LIGHT study, which Professor Mario spoke to us about in detail, and which showed that we could offer SLT as a first-line treatment. We can quite immediately offer SLT as an alternative to medical treatment after having diagnosed ocular hypertension or primary open-angle glaucoma. The place of the diode laser has also evolved with the new modality of diode laser that we will see. It is a subliminal diode that Emmanuel has already introduced. This technique is better tolerated and that we can propose laser in the evolution of the glaucomatous disease. In certain form of glaucoma that we do not want to operate on, also we can propose diode laser. And also when there is a risk of complication if you operate some kind of type of glaucoma. I will first talk about the SLT laser by first showing the evolution of the place of SLT in the management of glaucoma, and then by describing the techniques and protocol of the treatment. Then I will talk about the new alternative, new technique of subcyclo weakening, which is a subliminal diode laser. Here, there are some old recommendations from 2009, and at that time it was said that the treatment for primary open-angle glaucoma, pseudoexfoliative and pigmentary glaucoma are medical first. And in the event of progression, we propose surgery. We saw that here the laser trabeculoplasty was just optional. And in 2014, the recommendation had changed a little regarding the place of SLT. You see here, in case of primary open-angle glaucoma, pseudoexfoliative or pigmentary glaucoma, we put medical treatment first, then we put SLT, and then surgery. So the laser was no longer optional. In case of ocular hypertension, also we can propose medical therapy and then laser trabeculoplasty. But the LIGHT study had changed the practices since 2020, but because it is said that for primary open-angle glaucoma, so the exfoliative and pigmentary, it is either medical treatment or SLT. So you see, medical treatment and laser SLT is in the same place. So if you diagnose open-angle glaucoma or ocular hypertension, you can ask yourself the question of either medical treatment or SLT treatment. So now, regarding the techniques and the protocol, how do we practically perform an SLT? It is a very simple and easy procedure to perform that can be done even in the consultation room. In just 5 minutes, we will need just a lens to visualize the iridocorneal angle, which is here. Personally, I use the Latina lens, which does not magnify the images. The energy used is between 0.6 to 1.2 millijoule. Me personally, I use a lot of time, I use 0.8. It's enough to treat the patient and to see the champagne bubbles. It is known that the less the pigmented are the trabeculum and more the energy is required to see these champagne bubbles. We have two options also. We can treat 360 degree in one session, or in two sessions, 180 degree. That we should know is that we have to use 100 spot for the 360 degree, or 2 times 50 spot. Here in this image, we can see the different structure of the angle, iridocorneal angle here, with the 12 lines, the anterior trabeculum, the posterior trabeculum, the scleral spurs, and the ciliary body. So in this video, we see the spot shoots here just to the trabeculum with the appearance of the champagne bubbles, which testifies that we are using the good energy and that good localization of the trabeculum. We see here the bubble is what we represent just here at the right side. So if we show these bubbles, it means we are using the good energy. So before performing the treatment, sometimes there is some protocol. Personally, I give iopidine 1% 1 hour before, but not pilocarpine, because it modifies the configuration of the trabecular meshwork. The spot site is 400 micrometer, so it is wider than the trabecular band. So we don't need to worry about aiming the pigmented or no pigmented trabeculum. Personally, I treat 160 degree in one session, just to avoid patients having to make multiple trips back and forth, especially in our condition, where sometimes patients live far from the health facilities and access to means of transport is not always easy. In post-treatment, I just give a non-steroidal anti-inflammatory topical 3 times a day for just 5 or 7 days. So we conduct a study here in the Saint Louis Regional Hospital. It was a retrospective study of patients with chronic open-angle glaucoma. SLT was performed in 156 eyes, the average follow-up of 12 months. So indication was an insignificant IOP control or a discomfort or no compliance with the prescribed treatment. We divided the patient in 3 groups. The group A was the patient who received SLT as first indication, was 47 eyes. The group B was patient on monotherapy, and the group C, the patient in dual or more. So the criteria for success of SLT treatment was defined by a reduction in IOP of at least 3 mm at 12 months. So we studied the following parameters: intraocular pressure before the SLT laser, the treatment followed, the exchange of the glaucoma, the indication for laser, and the pressure result. So the result shows that we have at least 7% of patients that was classified as early stage glaucoma, 51% that was classified as a moderate stage of glaucoma, and 42 was severe glaucoma, depending on the time of evolution of the glaucoma. So we saw that the majority of our patients were on dual therapy or more, 49%. 21 of the eyes were on monotherapy and 30 was untreated. The average central cornea thickness of the patient was 528 micrometer. So what we show finally is that for the group A, we have a decrease of 8 millimeter of mercury from the initial to 1 year or 12 months follow-up. And for the group B, we have a decrease of 7 millimeter and 7.5 millimeter for the group C. So in conclusion, after 12 months follow-up, we get a reduction of 32% in intraocular pressure over 12 months after SLT. So that confirms that we can propose SLT as a first-line treatment for our patients, especially in Africa, with all the challenges we are dealing with in our daily practice. So the take-home message for SLT is that the treatment is a treatment option for most glaucoma patients, primary open-angle glaucoma, pigmentary or pseudo-exfoliative. It is a non-destructive laser therapy. It should be used as primary therapy as the light study showed us, or in combination with drug therapy or when drug failed. It gives us a decrease of at least 30% of IOP. Its efficacy with more than 80%. And what is interesting with this technique is that can be repeated anytime. There are small risks with IOP spike just after the procedure, some inflammation that can be handled with no anti-inflammatories. Sometimes patient can feel some headache, but it's cost-effective treatment for African countries. Now about the cyclophotocoagulation, the subliminal diode laser, that is a new method. It's a new cyclo-weakening technique, better tolerated than the conventional one that was transscleral cyclophotocoagulation. This technique aims to partially destroy the ciliary epithelium in order to reduce the production of the aqueous humor. It increases also an avascular evocation of aqueous humor that can lead to decreased intraocular pressure. I think the video that Emmanuel showed us explained very well this the procedure of this technique. So this technique also avoids numerous diode complications that we saw with thermophotocoagulation that can be EVs, loss of vision, cataract, hypotonia, or phthisis, etc. Here is the interface of the Subcylo with the one that I have here, which is a Cantel Medical Subcylo. The procedure is very simple and fast, just in maybe 160 seconds after anesthesia and patient installation. Not necessary in the operating room, it can be done in office. Personally, I use a subtunnel anesthesia because it's instantaneous and effective. In addition, it does not require a compression, so we can proceed to the laser just after anesthesia. In this video here, I was measuring 3 millimeters from the rhombus because I didn't have a trans-elimination, but we should know that the trans-elimination is the best way to perform this technique. So the trans-elimination is the key. Emmanuel also showed us how to perform the trans-elimination. The probe must be positioned opposite to the ciliary body, like this image showed us, through the sclera and 3 millimeters from the limbus, where the ciliary body are most often located. So in this video, we see the procedure here. It will consist of treating upper and lower hemisphere here, and avoiding 3 o'clock and 9 o'clock meridians. by doing slow back and forth movement, like here, while being perpendicular to the sclera. So it's a very simple technique and a very effective one. So in post-treatment, we just give a topical steroidal anti-inflammatory 3 times a day for just 5 and 7 days also. So here in this video, I just wanted to share a case study. It was a 64 years old patient on triple therapy with an IOP that has not decreased for 3 months. It was 34 to the right eye and 18 to the left eye. So we perform a Subcylo diet in the right eye with a protocol of treating the 2 hemispheres with 2 times 80 seconds with a data cycle of 30.3%. Just so in this video here, after performing the Subcylo, it was just in my consultation room with some colleagues. It takes us just after anesthesia, it takes just 2 or 3 minutes to perform this technique. So after performing the Subcylo, 1 week after, the IOP was decreased at 13 millimeter. You see that in 1 week, we passed from 34 millimeter of mercury to 13 at the right eyes. And after 3 months, it was 15 millimeter of mercury with the conservation of the initial visual acuity. Currently, the patients are in a dual therapy with a well-balanced IOP. So what are the indications for Subcylo? Can be the refractory glaucoma. In case the filtering surgery is failure, a neovascular glaucoma or aphakic glaucoma. In the early or moderate glaucoma, in case of poor compliance to the meds, we can propose Subcylo. In case of ocular surface disease also, or the tolerability issues with the medication, or sometimes in cataract surgery combination also, we can propose it. Some particularity in the sub-Saharan areas specificity. In case of non-acceptance of surgery, we can propose to our patients this technique. In case also on availability of glaucoma surgeon, because we are dealing with here in Senegal, in some region we don't have a glaucoma surgeon, so it can be a very good alternative to propose the Subcylo. Sometimes it can be also due to the cost of the surgery. So in conclusion, how do we rank laser in glaucoma management? We should ask ourselves this question, because it's becoming increasingly clear that we should change the paradigm of using SLT as a primary therapy. And we should consider laser procedures that preserve the ocular tissue, such as Subcylo diet earlier in glaucoma management, particularly in Black African glaucomatous patients, whose progression remains very rapid and with often poor medical therapeutic compliance with our patients. Thank you for your attention, and I give it back to Emmanuel.
Yes, thank you, Dr. Sow. Thank you, Professor Mario. Now we will do the question and answer session. Okay, so I have noticed that we have already some questions. Okay, sorry. Yes. If I go to the questions, so one person, one doctor asked about the use of MLT. Okay, MLT is another technique. This is not exactly SLT. MLT means micropulse laser therapy, which is a variant option from another company that use a different application time from the laser beam. So in comparison, we don't have too many data about the MLT technology, not enough proof about the efficacy, certainly, but about the possible repetition of the treatment. With SLT, with more than 25 years experience about SLT, now we are sure that it is a procedure that it is repeatable. With MLT, we don't know yet. So, Professor Mario, if I am wrong,
it's correct. And there is another factor also. As you already talk as is well proved, well known, with a lot of scientific evidence. And this is important also in questions of inversion. When you have an SLT, because you have a jack laser inside, you can have the double option. You can have the SLT plus the jack laser in the same unit. And this is probably an advantage when you need to distribute your money in the best option that you can have. Then, not only because the reason that Emmanuel said, but also because it's well proved in its scientific approach. I think SLT, okay, MLT can do that, but we must see what is the best option for us always.
Another question. Do you recommend SLT in patients with advanced glaucoma who have been on treatment or on diagnosis?
Dr. Sow, please.
Yes, definitely we can recommend SLT in patients with advanced glaucoma because as I showed you in the study we conducted here, we saw that a decrease of 7.5 millimeter for the patient with advanced glaucoma. So it can be recommended for that.
Yes, I am totally agree with you. And also I want to add, okay, you can also add SLT in every single part of the treatment to reduce the uses of drops. Using drops and SLT at the same time is not a controversial thing. It is possible. And also you can decrease when you are in maximal therapy with drops, we can decrease one of two, it all depends on the results for the drops. And this is something that we must take in account. The question is, even we can recommend, but be aware the most effective decrease of the pressure should be in naive patients, and also, I mean, patients that have no treatment at all, and with, in my experience, in between 29 and 32. And that's the reason to say, okay, this is the reason why we say we recommended it, highly recommended it as primary line, first line, because people is not convinced about it. But we have a lot of evidence to do that, and this is easy. If you ask the patient, okay, do you want to have every single day of your life eye drops, and you have glaucoma, it's a long-term situation, and then you have the possibility to have one session of laser or two sessions of laser, and then stop the drops, and also let's see what's going on. And we can repeat it because Dr. Sow and Emmanuel, they told us there is no thermal damage, is a photothermal lysis. This is the mechanism totally different. I think if they offer me that, I say, okay, I would like to have only one session or two sessions of SLT instead of using the eye drops. Going back to the question, if you are using several drops in a very advanced glaucoma, and I tell you, okay, I want to have the experience with SLT just to reduce the uses of the drops for the compliance, for the quality of life. Remember, eye drops, they lead to dry eye because some molecules as well as also because the preservants that they should have. Then You have a patient that have red eyes, the patient that has discomfort, the patient, and then you can solve it with SLT as well.
Another question. For patients on medical treatment following SLT, when do you drop medications?
Dr. Sow, you want to answer that?
Okay, I can give my experience maybe. Just for me, for patient on medical treatment, I drop the medication just after performing SLT for the patient who was in monotherapy, not in dual therapy. In dual therapy, we have just to reduce the number of drops. But patient with the naive patient or the patient who was in monotherapy, after performing SLT and that after 3 or 6 months follow-up, I saw that the IOP was not increased, it is decreasing. I can drop the medication, but we don't have to leave the patient after. We have to make a follow-up to see that if the IOP will still decrease or will still normal.
Yes. Tell you also my experience is very similar. Okay, I have the patient. I used to perform the SLT. Then I myself observe the patient 1 hour later to see if the patient has some spike. I agree with Dr. Sow. I use Jopidine or some primidine, yes, before the treatment. No pilocarpine as well. No anti-inflammatory as preventive, because we are causing a light inflammation with the SLT, and we do a subtle reaction just to clean the trabecular mesh for our immunological system. Then I observe the patient 1 day later, and then I decide if the pressure is as low as I expected, then I stop the medication in the naive patients. I see the patient 1 week later and have the control of the pressure. If I don't have any issues with the intraocular pressure, is rising or not, I have no medication as well. And if I see 1 or 2 weeks, in my experience, according to the Dr. Sampaolesi protocol, I release a second treatment with SLT. And it helps me a lot because I can control the pressure, and some of the patients don't need to have eye drops as well. But Dr. Sow said something that is very important. Follow-up is the most important thing. There are patients that they maintain no eye drops till 1 year, others 2 years, and they don't need to repeat because the pressure is not. We are not treating. We are treating patients, not pressure, and we must be. We are treating patients. It will be in our mind, and the pressure is indicative, but very well. But if we see the decrease, we can be confident with the results.
Okay, thanks, Professor Mario. Another question that I'm not sure I've understood correctly. Is there a risk of loss fixation after SLT? What does it mean? Last question on the chat. Is there a risk of loss fixation after SLT? There is no incidence of the laser SLT in the site or for the patient. Just right after the SLT laser, it's a safe procedure. There is no risk. It will be my answer.
I never have the patient with loss of fixation. Loss of fixation, that means you have no macular fixation. But this is not the area where the SLT is acting. I mean, if this is the question, no,
maybe the question is related to how we do the SLT laser. We do not aim the center of the lens, we aim the mirror. And then we
Yes.
target the angle. There is no target at the
Correct.
macular level. So there is no risk for the macula if we target through the mirror and target the iridocorneal angle.
But
Okay,
never
maybe,
happens.
maybe Mr. or Mrs. Ziad, you can just add more details if we do not answer your question.
Yes.
Another one, what is your experience in repeated SLT? How far apart do you recommend between treatments and how many times?
Okay.
Maybe Mario, you have a lot of
I
experience
let
on
our
that.
colleague from South, because this is the nearest experience for all those people. I can add also my experience, but I would like to hear Dr. Sow about his experience in African patients.
Okay, so I have a little experience about repeating SLT. What I can say that, as we know, the SLT can be repeated anytime and anymore we want. The important thing is that if we don't reach the IOP, the target IOP, we can repeat it with our patient. It happened to me to repeat the SLT in 1 month, sometimes 2 months or 3 months, depending on the evolution of the IOP of the patient. But what it is interesting to know that there is no complication for repeating SLT for our patient. Just
Yes, I totally agree. I have experience with SLT for more than 8 or 9 years, and the repetition, it was very funny. In the very beginning, I was, okay, we're talking about 8 years ago, 9 years ago. People was a little bit scared about the SLT and the results. I myself, I began using only 180 area for the treatment. And in those patients, I must to repeat more time. When I shift to the 360, I mean in 1 or 2 sessions, the rate of decrease of the repetition, the rate of the repetition decrease. That is important. Yeah, and that is for me. Also, as Emmanuel said, 360 could be the ideal treatment. It could be in 1 or 2 sessions. It all depends on your patient. I prefer to do it in the out clinic for 1 session, but is at least one. The rate of repetition was very low in 1 year, increase in the 2nd year and the 3rd. As Paul said, don't be worried about that. This is not ALT. It's SLT, not thermal damage. You can repeat anytime, anywhere. When you see that the pressure is increased, you can do that. How can increase the pressure to make the decision how I will repeat? Then for me is the deviation of the target pressure is more than 20%. I consider to repeat the treatment.
Okay, thank you. Another 2 questions in one from Dr. Nelson, Kenya. Do you have experience with SLT in unsuccessive post-glaucoma filtration and filtration surgery? And in the future, do you think SLT may have role in congenital glaucoma?
Normally, okay, for me, I can answer that. For me, there is an schema. I always begin with SLT, first line. Then I evaluate the patient. If the results are not good for me, then I go to repeat, as I told you, the 2nd SLT treatment 1 month or something like that. Then, if I have no results, I turn to Subcylo. I mean, I try to be no invasive as well, and then the next step is the surgery. And normally, if I have a filtration surgery, that means okay, I'm escalated. then I don't go back. I can, okay, if I am right in the situation that I should do a filtration surgery, that means that I am in the extreme. I am step by step. What happens when you receive a patient that have an unsuccessful post-glaucoma filtration surgery? Can you add it? Remember, you have an area that you can't do that, but you have another area that you can make the treatment. What is the rationale of the treatment already? So the rationale of the treatment is to clean the trabecular mesh work. Normally, everyone have obstructions in a general part of our filtration mechanism over the 40 years. It could be very mild. It could be very extensive. The extensive cases, they develop glaucoma. The very mild, okay, pressure seems to be higher when you are getting older. This is no problem. And if you can add, yes, if you receive a patient, I think, or use drops or you use SLT. But to tell you the truth, if the patient has a filtration surgery, my next step is valve. For me, this is go to the valve, AMET or whatever. This is my opinion. This is a pathway that you move for the simple to the more complicated. If you have a patient with filtration, that means all the things before doesn't function, and you must go in advance. Any other comments for the panel? Okay.
Okay, perfect. I think we've done.
Thank you for Emmanuel, Emmanuel, there's a question about the congenital glaucoma as well from the same doctor.
Yeah, the congenital, really, for me, is for what happens in the congenital glaucoma, you have a lot of dysgenesia or relationship for the trabecular. I mean, for those cases, you have a problem with the genesis of the trabecular meshwork, the connection with the iris, with the corneal opacities and so on. Then you have a lot of situations with Axenfeld rigor. You are not able to see the trabeculum as well because there are a lot of things. In some of them, you have the Barker membrane. I mean, to do SLT, you should be able to use to see the trabecular meshwork. If you can see, you can treat. But in congenital, not always you can do that. We are waiting for more things about that in the future. We can talk about it later. But for me, I think congenital is something that you must act also quick and not more aggressive. It should be the real conduction for the treatment of those patients. Be a little bit more aggressive. I mean, surgery has more impact in that kind of patients.
I completely agree with Dr. Mario. I think what it can be interesting in the future is to see that the role of the use of the Subcylo in the congenital glaucoma. It may be more interesting, I think.
We lost. I think it's the end of the sessions. We don't have more than 2 hours. We exceed the time, so maybe it will close automatically. Sorry for that. Thank you, everyone. And thank you, everyone, for attending.
Just for finish, that Dr. Sow said, yes, I am agree with you. Is it? Perhaps we must do a next session concerning what is the role of Subcylo in that patients. And there is something interesting with UVM because in the ciliary body in adults is totally different than the ciliary body in children's. And sometimes the protocols, they are not well oriented because the people don't use UVM to see what is the position. We have a nice presentation about that. We can do it in the future, how we can solve I mean, more aggressive, let's go Subcyclo, so let's go Thermocyclo in some cases, but SLT, I think, is not at the moment possible in that kind of patients.
Okay.
Emmanuel, there's
last
one more
question.
question. Yeah.
Yes. After SLT, we systematically stop the eye drop, or it is according to the IUP. I think there is 2 points of view about that, depending if you can do the follow-up or not. So, Dr. Sow, it's up to you to answer according to your experience. But so far as I know, the recommendations are if you can do the follow-up, you can do the visit 2 weeks later, and then according to the IOP, decide if you reduce the number of meds. But regarding your situation in countries like sub-Saharan countries, Dr. Sow, it's up to you.
Okay. After SLT, what I can say is that we don't stop systematically the eye drops. It depends that if we reach the IUP target that we target, okay, we can stop it. But what is important is the follow-up. We can't stop the treatment and let the patient go. We need to see the patient again and again to see that the IOP is still normal or is not increasing.
Yes.
Yes, Professor Mario?
Yes, totally agree. IOP is the leader of our conduction of the patient.
So yes, according to guidelines, usually don't forget that there is the follow-up is important. So usually 2 weeks or 1 month later, and at 3 months or 6 months at last.
That is
and
the
every 6 months, if you can do it.
Yes, this is my protocol as well.
Because we know that the glaucoma is still this is not curable. So obviously, either you use drops or SLT or cyclodiode laser, the follow-up is key. Okay, so maybe it's time to say goodbye. Jamin, can you conclude a bit, and we will go back to our other activities.
Yes. Thank you so much, Emmanuel and Professor De La Torre and Dr. Sow. I think it was a very useful and very, very interesting presentation. And I think some really good questions from the participants as well. So thank you so much for taking time out on a Saturday to impart all this knowledge to us. Really appreciate it. Thank you so much.